Oh, we're live now. All right, I think we're ready to go. My name is Al Taylor. I'm a medical informatics officer at in the Office of National Coordinator. I'm going to be moderating today's discussion on health IT in specialty care settings. I'm joined today by Chip Hart from PCC, which is a pediatric-centric EHR, as well as Shelley Spiro, who is the executive director for Pharmacy Health IT Collaborative, and Alex Tyra, who is regulatory affairs director for the Ambulatory Surgical Center Association. We're going to be talking today about several aspects of health IT across the care continuum, and specifically in specialty care settings. The 21st Century Cures Act, which was passed in December of 2016, required, amongst many, many, many other things, ONC to encourage the voluntary certification of health IT for use in medical specialties and different sites of service for which no such technology was available, or where additional technology advancement or integration was necessary. And that covers quite a bit of ground, but it involved areas that were not incentivized using the EHR incentive program. There's two particular requirements in the 21st Century Cures Act. One was that HHS will solicit public comment on specific specialties or sites of service for which that additional development was necessary. It also called for the development of health IT for pediatrics in particular, including making recommendations for voluntary certification for health IT for pediatric providers to adopt certification criteria similar to our own health IT certification for meaningful use and for the HR incentive program, as well as to support voluntary certification of health IT with pediatric providers. Prior to the 21st Century Cures Act, a lot of this work was already being done based on recommendations that were developed through the Children's EHR format, which was a really quite large multi-stakeholder effort, included private and public work to develop. Really, at first, it was hundreds of recommendations or requirements for health IT to support the care of kids. It was then refined into the top 47 recommendations, and then it was further distilled into a top 10 priorities based on recommendations by the American Academy of Pediatricians. As publishing the ONC's Cures Act final rule, which has a much longer name I'm not going to get into, we took the approach to address the Cures Act, the 21st Century Cures Act, by identifying existing criteria in the ONC 2015 or the Cures Update certification criteria that did support many of these priority recommendations, and the extent that they supported each of these recommendations. Also, we worked to identify areas that did require further development that might not be completely covered by the certification criteria. ONC continues to work with other medical specialties and other sites of service to identify opportunities to develop health IT and health IT recommendations to serve these areas better. Today, we're going to discuss the path that led to the certification criteria for the pediatric certification criteria that we published in the Cures Act final rule. We're going to talk about the path that ambulatory surgery centers are taking, and how far they've come and where they're at now. The ambulatory surgical centers is one of the sites of service, sort of the first out of the gate as far as alternate sites of services. And then we're also going to talk about ancillary services to support direct provision of care, including pharmacy. pharmacy services and pharmacist services. I've introduced our panelists today. Each of them have been involved quite a bit over the many years, certainly the many years that I've known them, to help develop health IT capabilities within these specialty settings and sites of service. We're going to start with Chip. Chip, you've been involved with the child EHR format for a long time, as long as I've known about it, and probably longer. I'd like to start with you and see if you can talk about how the whole pediatric EHR health IT and certification started, why it started, and how we've gotten to where we're at today. I'm going to turn it over to you. And where are my slides? I'm going to turn it over to.
You're right there. I see it.
Wait, there it is. So all up to you, Chip.
All right. Well, thank you. And first of all, just to give a little bit of background, because I do feel a bit like an interloper. I am not a physician. I don't represent a society or an organization that represents other pediatricians. I literally work for a software developer. I'm one of those people who, in the good old days, I used to actually do a little bit of the coding myself, but I work for a vendor. We're an EHR vendor, but what makes the reason we're here is we only have pediatricians as customers, and we have a lot of experience, a tremendous amount of experience, just being in the offices of ambulatory or private practice peds and watching how they work, which is how we got involved. And so I'm often uncomfortable in circumstances like this because it's not the audience I'm used to addressing, or the things that I know a lot about are not regulatory. But that said, going all the way back, Al, as you pointed out, to the model child EHR format, the pediatricians have been left out of the HIT discussion pretty substantially from the beginning. Now, I realize every specialty or every subspecialty, every organization or group that has a focus feels the same way, that they have their own special needs and that the one-size-fits-all model doesn't work well for them. And that's all true. But there are two enormous factors that affect pediatricians that led to the child EHI format that led to where we are today. Those two factors are this. First of all, pediatricians, as a rule, don't take Medicare. It's very rare that they do. And so the carrot and stick that is used for all the other specialties is not really used for pediatricians. Now, everyone here knows that got managed by making that a Medicaid program, but that still means that only a subset of pediatricians qualify for meaningful use, which meant that there really wasn't a lot of attraction to pediatricians to become meaningfully use certified. The other thing that really is substantial, and I realize there are some other specialties who share this focus, but if you've done a lot of the reading, you can look through all the requirements, as many of us have done. You'll notice that a lot of the feature requests have to do with things that physicians need, that clinicians need after someone has become sick. And pediatricians are mildly unique in that they focus incredibly on preventive care. There's a lot of projection into what someone's going to need in the future or what services they are missing from the past. And that's a little bit different from perhaps recording the event of what's happening right here. Now, there are plenty of other differences as well, but those two things meant that the pediatricians often didn't have a great seat at the table. And so, as Al mentioned, I think you gave the number, Al. Do you remember what the original number of requirements was?
It was over 800.
Yeah, and I was involved with that project. And in fact, one of the things that our company did is the Chipper folks would call our customers and go over, I think, like all 800 features and say, which features does your software system have? And I will tell you, even within pediatrics, there's a pretty enormous split between ambulatory peds and hospital-based peds work. And we don't do much of the hospital stuff. So there are huge swaths of the of the model format that we didn't cover. But even within the stuff that we knew in our hearts we did really well, our customers would say, oh, no, they don't do that. And then there were times when our customers would say, oh, they do that even when we didn't. And so I know this sounds like a crazy example or story, but there was a huge amount of chaos. And when you have 800 features that you have to write to, that is really, really difficult. So as Al pointed out, the list got pruned down to 47, and I can tell you, because I was in the room and I was a vendor, that list of 47 was still too large. And to the credit of those who did the work, to take that final list and get it down to 10 priorities for pediatricians, to make that all part of the final rule, is actually a pretty substantial game changer. Those of us who work in this environment, and if you deal with pediatric HIT, it's been the same usual suspects for 20 years. We all know each other. We've all been working on the same problems. We actually see light at the end of this tunnel, where we look at it and we realize, hey, even within the places where there's still differences or perhaps it's not appropriate, we can see how to accomplish this. And in my opinion, the single biggest, perhaps most revolutionary thing that the final rule brought to the table is there are the two words, bright futures. So the AAP, I don't know much about other specialties. Alex, maybe you can tell us later, but what happens in the ambulatory surgical realm. But in pediatrics, pediatricians actually have a gold standard of care that is documented and outlined pretty well. It's called Bright Futures. And it tells you at a 4-year-old well visit, you're supposed to ask these questions. You're supposed to provide these services. It's, from an IT perspective, it's a blueprint that you don't usually get in other circumstances. And until the ONC, until the meeting where that list was defined down to those 10 elements, those words had never actually been formalized anywhere. And in the broad scheme of things, when it comes to patient safety, when it comes to improving the quality of care, given that more than half the teenagers in this country do not get depression screening, given that we just in the last 3 months alone, we've seen a dip in immunization rates of about 3 or 4%, I measure it, to finally have software that specifically aims at improving the quality of care in children is, in our little tiny niche of the healthcare continuum, a revolutionary change and a positive one. And the people I know, including our direct competitors, but friends, this is exciting work, and it's actually kind of cool to be here at this stage in its development. So I hope that answered your question.
Yeah, it did. So Chip, one of the things, because when we were talking about the implementation of Bright Futures and other practice guidelines in general, but when we're talking about pediatrics, we're talking about Bright Futures.
Yep.
As far as practice guidelines go. Early on, even I think it goes back to Meaningfully Used 1, or shortly, maybe MU2. I'm going to get in trouble for using that word, but I'll say it anyhow. There were some clinical quality measurements that were developed and codified and made Health IT enabled that come directly out of Bright Futures. So 2 of them are the immunization schedule, specific, at every well-child visit, a practitioner is measured on the currency of immunizations for the given age. Pediatric dental care, dental sealants, and things like that. Those have been implemented, but those are just a couple of the many, many Bright Futures recommendations. What do you see what was the barrier to, because I think people knew that each of these were chapters out of the Bright Futures. Mm-hmm. What was the barrier to just saying, why don't we build out 10 of them or 20 of them instead of 2?
That's a great question. There are a couple barriers. First of all, even predating, or not necessarily predating, but concurrently with the model format work, a bunch of us remember CCHIT, and I was part of the committee on pediatrics there, and I was sitting down with the pediatric IT cognoscenti nationally, and we bumped into what we thought were the lowest hanging fruit for pediatric decision support and guidelines. And so, okay, the big example was growth charts. So growth charts have been part of meaningful use from the beginning, all right? And it was something that was kind of weird that a lot of EHRs didn't do it. But the assumption was, all the way back at CCHIT, we're all in a room, and someone said, all right, we not only need the growth charts for WHO and for CDC, but we need the growth charts for preemies and kids with Down syndrome and Turner syndrome. And people started listing all of these special condition growth charts as though, and we all agreed, we're like, absolutely, if you are a pediatric EHR, you need to have Down syndrome growth charts. Little did we learn, or little did we know rather, and it took us a little while to learn, the Down syndrome growth charts didn't exist. Even though they were out there in the wild, they weren't peer reviewed, they weren't actually statistically valid, and a lot of EHRs had actually adapted some that were literally made by pencil, and then someone codified them. And where I'm going with this is, what we keep bumping into, Al, is many, many places in medicine where it's obvious what should be there in terms of clinical content to support the decision making. It's missing for pediatricians specifically, because the work hasn't been done. The biggest obstacle, the biggest gap we're going to get is with prescriptions, dosing in particular. We helped, and as did many of the usual suspects who also worked on these programs. We did some work with Vanderbilt that did some analyses of dosing, pediatric dosing, and maybe Shelley might. I'm not trying to talk about this, but as she knows, she'll probably nod. Dosing from physicians is horrifying, frankly. And on the pediatric side, one of the problems is that there is often not great pediatric clinical reference or clinical guides for what's appropriate with dosing. And so this entire process has shown the light on the gaps that exist even before you can get to IT. You can't talk about having a computable immunization schedule if 5 years ago the clinical decision support team from CDC didn't actually finally put some computable language together in order to do that. We couldn't have a pediatric IT certification that involved immunizations until within the last decade, even less, because a lot of that framework didn't even exist. And so now it's being built now. And I'm hoping that this will actually trigger a lot more pediatric architecture for everybody. Let me add one thing. I'll spare you from having to ask for it. One of the things that ONC produced was the developer guide. The official term, I'm failing at it right now, but it's the pediatric the guide for developers for pediatric HIT, and the guide for physicians, the providers themselves, is coming out shortly. That guide is fantastic. If you are a developer, if you are wading into having to work with in the world of pediatric HIT, it is probably the best public. So it's not probably. It is by far the best public source for pediatric HIT guides to give you, to level set your understanding of what's out there in the wild, where you should start. They've done good work. I'm very cynically, normally I would get a document like that and be like, yeah. They don't know what they're talking about. They don't know what they're talking about. But they in fact talk to all the right people, and the guide is really good. And the proof of this is when I have people who work in my company come to me, this literally just happened on Friday. Someone came to me and said, "Oh my God, have you seen this document?" And I was like, "Yeah, we helped participate in it." It was that was actually a really good sign that someone without guidance found it, ingested it, and said, "This is an amazing resource." And I said, "Yes, I sent it to you like 3 weeks ago." That the document's that good. And so anyway, to really directly answer your question, some of the biggest obstacles to our surprise, continued surprise, is the lack of computable support underneath the framework that the pediatricians need in order to put those tools into place. But it's coming, and it's coming. We've got good stuff now, but it still needs to be a lot better. We're just at the beginning of it.
Great, and you see that developer and provider resource as helping, even though it's still a voluntary certification
Absolutely. Absolutely. Now, if you go and find the developer thing or the developer handout, one of the things you'll see is that for each one of the functions that they want you to focus on, it almost always says in every one of them, but there still needs to be more work done to establish the this clinical guideline. But what it does do is assemble in one place the fundamental pieces you need to get your head around. Pick any one of the things, but one of the options one of the items is to identify lost opportunities for preventive care, which references very specifically Bright Futures. And I will say, even among pediatricians, I routinely have to introduce them to something called the Bright Futures Periodicity Schedule, which is a big table that has a full grid of what your expected services are for pediatricians. Now, I wouldn't expect, Alex has never seen that. I'm picking on Alex just because, he's right there on my screen. But that's not something you would ever see in an ambulatory surgical center. So I would be stunned if he knew about it. But if you're dealing with pediatricians, you have to know about it. And for the guy to actually bring that to the forefront and say, start here with your education, and here are the big issues right now, I think it's really well done. And I was grateful to see that work.
Great. Thanks a lot, Shep, for that background and kind of a good overview of the arc of the work that the whole group, not just you, but the whole group.
I was that much. I
think we all were that much of a bigger part.
Yep.
I'm going to turn it over now to Alex Tyra from the Ambulatory Surgical Center Association. And he is going to talk a little bit about how ambulatory surgical centers have addressed their health IT needs. Some of this has to do with their status as eligible providers or eligible hospitals, if you will. But I wanted to give him a chance to talk about how surgical centers have come to address their health IT and also to solve their health IT needs. So I'll turn it over to Alex and take it away.
Thanks, Al. And thanks again to ONC for having me as part of this panel. I know we've had talks similar to this before. And I would say just to start that our work in terms of the ambulatory surgery center sphere is very ongoing. And it's been really helpful to have pediatrics gone through somewhat of a similar specialty care process before us, because I think there's many lessons that we can learn from their decades-long process that we're currently trying to enact. And we're just kind of at the start of our process in terms of developing health IT standards, recommendations for our sphere. So I think a lot of what I'll be talking about today is much more about process and our thinking going into this process and what kinds of things we're focusing on as we kind of try to develop and try to implement more health IT in our space. So I wanted to start maybe with just some background on ambulatory surgery centers, obviously freestanding outpatient surgery centers, a lot of diagnostic and preventive services. For the last 10 years, we've kind of grown to have a few high volume procedures be our staples. So 75% of Medicare cataracts, 50% of Medicare colonoscopies. Those are kind of the bread and butter for ASCs. But, there are some structural barriers, I think, to health IT implementation or kind of developing any sort of concrete centralized structures. There's 5,800 ASCs, and they have very diverse specialties. Some of them are small single specialty centers, and some of them are bigger multi-specialty centers that are doing, many different kinds of procedures day to day. And obviously the types of EHRs that they would need would differ greatly between those centers. Also different management structures. So some of them are independently owned and operated by physician groups. Some of them are joint partnerships with the hospital. Some of them are corporately managed by somebody like, a Tenet or an HCA. And I would say that the last thing is just kind of that being in between a site of service. So, a lot of the times the primary patient relationship isn't going to be between the ASC or isn't going to occur at the ASC because you're kind of going there for this one-day procedure. It's going to be at the physician office or at the hospital. So kind of living in that in-between historically has been a major barrier to getting a specific kind of health IT standard developed for this space. That being said, I think we, as the association and, kind of just in the macro sense, are looking forward and know that health IT implementation broadly is going to be imperative as we move towards more value-based payment programs. We're looking at care more holistically across the care continuum. And then just needing more data. ASCs are growing because outpatient surgery services are growing. And, we've seen a lot of complex surgery procedures and specialties such as spine and cardiovascular and certainly orthopedics, total joint procedures start to migrate. And I think capturing data will be imperative as these things move to the outpatient space. And that being said, ASCs are general ideas that we probably have about 25% EHR penetration, which is obviously extremely low compared to hospitals and physician offices. We think that new centers, newly constructed centers, are taking up EHRs at a much higher rate, probably 90 to 95%. But ASCs are also growing slower than they were in previous decades, probably only 100 more maybe every year. So obviously addressing those older centers that only have the 25% penetration, that are doing a lot of their work on paper charts via fax, that's a huge issue for us. So Al had mentioned that we had some exemptions written into 21st century cures. Basically, because of the low penetration in our space, there was some idea that clinicians who perform most of their procedures in ASC shouldn't be penalized in value-based programs for using an ASC, especially since, for certain procedures that are appropriate, ASCs are thought of as a cost-saving and efficient site of service. So there is a section in 21st century cures that says that there's no payment adjustment for any physician that's furnishes substantially all of their procedures in an ambulatory surgical center. And that substantially all figure was later defined in the 2018 inpatient rule as being 75% or more of covered professional services. So at least from a Medicare MIPS perspective, there's no downside for having the low penetration in our space. Historically, as with other small provider types, we've had the promoting interoperability category reallocated to the quality category. That's kind of standard process there. So now I think maybe I'll move into just talking a little bit about what the work is that I've been doing and kind of addressing this. It's really been slow, kind of building it from the ground up. And that's why I think the pediatric model has been great. One of the things that I did first was to just start convening calls. So this was open to facilities, this is open to vendors, basically anybody in our sphere who wanted to talk about EHR-related regulatory legislative updates, talk about, challenges that they might be facing in their facility specifically. And that kind of opened up a forum to get some feedback about what we might be, kind of the environment that we might be dealing with in terms of health IT in our space. I also convened a smaller work group that is mostly comprised of vendors, but also had a GI doctor from our board, also had some of the corporate technology people, CTOs. And that group worked towards a couple things. One was a white paper that we wrote that I could possibly link to in resources that was kind of just like solidifying and being able to say, in 2 pages, what is the actual need for EHRs in our space, for certification standards, for any sort of health IT standards. That included obviously patient safety and quality, talking about the need for that, talking about interoperability, and like I was saying, kind of ASCs providing a link between other sites of service that are also capturing data electronically. And then finally, for just, stimulating vendor development, which is kind of a possibly crass way to look at it, but a lot of the, vendors aren't taking up products for our space because they're worried that, if there are guidelines that come out in the future, they will spend time and energy developing a product that isn't applicable to whatever standards are going to come out. So we wrote this white paper. We also took a look at the 2015 edition criteria themselves and kind of worked hard into delineating which ones of the criteria would be most applicable to the ASC space, which ones maybe would be less applicable, and ones that maybe in their current state would be applicable, but maybe with some certain caveats. And I think those, the criteria work and the white paper work together have been really good building blocks in terms of working with ONC and their Office of Technology and their Office of Policy, and kind of, giving us a framework for moving forward and showing what types of health IT products are going to be most applicable for us. So then we've also kind of done a lot of other just general stakeholder work. We asked some of our specialty society partners to ask their governance committees and to ask their members about clinical goals. One of the things that I think we took away most from the pediatric experience was really centering on the patient safety, the clinical side of it. You need every facility, from a macro perspective, it would be great for us to get the data, like I was saying, and for the macro interoperability to be there. But when we're talking to the individual facilities, the value proposition that we need to give them is that this is going to be better for your patients. It's going to make delivering care more safe and more efficient. And so talking to the clinicians that are operating there and kind of outlining some clinical goals, I think has to be a primary part of whatever work that we're doing. I think we needed to do a lot of education. So talking about speaking, at our ASC State Association meetings, talking to members has been a big part of it. Strategic partnerships, again, we worked closely with registries. I think we found as one of our big partners because they have an incentive to help us bring up EHR uptake into our space because they want to be capturing data. We work pretty closely with a bunch of our specialties. So people like AJRR, which is the Joint Replacement Registry out of AAOS, or the IRIS Registry, which is ophthalmology's main registry, have been really good partners. And then I think recently, and kind of what is the centerpiece of our current work with ONC, is talking to the vendors. So I think within the next month or so, we should be convening a good roundtable with the ONC's Office of Technology and with some of the main vendors in our space to talk about not just some of the challenges that they've been seeing and kind of think about technology solutions, but also some of the newer things like Fire-based APIs and some of the kind of incremental steps that the vendors could be taking in developing products that may help centers who aren't ready for a full wraparound EHR implementation, who don't have the time and resources to develop to that, but maybe want some sort of interim product that can connect into the larger EHR in the hospital or the physician office. So that's kind of where we're at now. And like I said, I can share some of these resources. I'm happy to share some of these resources afterwards if there's an opportunity to.
Yeah, thanks, Alex. I had a couple questions. For you. So you mentioned you talked about finding EHRs that better serve the existing EHRs that better serve the needs that might better serve the needs for ASCs, whether they are comprehensive EHRs that also have an inpatient surgical service component to it. How do you go about, how does ASCA go about identifying which of those as sort of, it sounds like that's sort of as a service to ASCs to identify for them which of the products might be able to address their needs better?
I think a lot of the work there has been just working with the vendors themselves. I think the nice thing about our space is that we have, so obviously some of our centers have the major EHR vendors implemented in their facilities, but it's been really great because some of the companies, the developers that have been focused on ASCs, it's a pretty small community, so probably single digits, companies that are really their main value proposition is looking at ASCs and developing products for ASCs. So kind of just giving centers the ability to connect to some of these vendors, I think, and has been kind of our main strategy.
Okay. Does ASC give some sort of, do they sort of designate any particular EHRs? I'm not asking for an endorsement, but you don't give that, don't give that sort of endorsement, but more guidance on where they might find EHRs? No,
and this I think is broadly a big focus for me has been in this whole process being very vendor agnostic. So whenever we convene groups or we're pushing stuff out to our members, trying to be very just, all vendors are equal in our eyes and allow them to kind of give their sales pitch to the members. And then from the advocacy side, when we convene this roundtable with the vendors, I've asked them all to have the same number of representatives attend. When I was doing some of the work group work with the vendors, they were also limited in terms of how many representatives could be on the calls, just so that we could keep it as focused on the industry and kind of on the process rather than on a specific product.
Okay. Given another question for you, given that ambulatory surgery centers are unique in that they are, for the most part, detached from large practices, large hospitals that have more comprehensive services than ASCs, and it seems to me that interoperability is maybe more of an issue with ASCs because they don't keep any patients, they take them and then they send them. Mm-hmm. Where are some key, as far as you know, what are some key functional requirements or using ONC certification criteria to the extent that you know about the details? What are some key requirements and functionalities that are maybe more unique, if you will, to ASCs versus other more broad-based practices?
Yeah, I don't know because again, it's really tough. I think when we were looking at the criteria, one of the things that I really noticed was just depending on what kind of centers you were working for, it was really different in terms of what your clinical needs would be. So I would say almost the only thing that was common to all of the centers was a lot of the kind of, demographic criteria. I know demographics is one of the criteria, but kind of just the basic patient, medications, allergies, that kind of stuff, clinical decision support, that sort of thing was most common. And then everything else was kind of, it would depend on whatever center you were talking to.
Okay. All right. Yeah. So we have a question. We have a question from the audience, from Ashto about that resource. Could you provide a link to everybody and answer that question that's in the Q&A with a link to the resource you were discussing?
Sure. Yes, I'll do that now.
And if you, just let me know if you're able to, great. If not, we'll help you out. All right. Well, thank you, Alex. I'm going to turn it over now to Shelley Spiro from the Pharmacy Health IT Collaborative. Shelley has been working for a very long time. She did a lot of work with the pediatric EHR format and the pediatric certification requirements, and has also been working to address some unique issues around interoperability requirements and health IT requirements for pharmacy and pharmacist services, as well as other ancillary services. So I'm going to let Shelley talk a little bit about how the work that she's done across these ancillary services and the health IT requirements.
Well, thank you, Al, for the lead in and introduction, and I also like to thank ONC for inviting us today to speak. And good afternoon, everyone. First off, I'd like to give a shout out to my allied healthcare providers, the other allied healthcare providers, which, include pharmacy, may include dietary, rehab, social services, physical therapy, occupational therapy. We don't realize, especially as we get into the aging population, how many of these services need to be integrated into our primary care practices and also shared as our patients move from one practice setting to the other. And I saw this quite a bit, especially with my long-term post-acute care background. I've actually been a member of the LTPAC HIT Collaborative since its inception. I think it's well over 15 years now. And when we formed the Pharmacy HIT Collaborative, we looked at things in a similar way that we do with our other allied healthcare providers. We, in pharmacy, have aspects in all practice settings that a patient has an encounter in, whether that's a hospital, a clinic, a primary care practice. ambulatory surgery centers, our pediatrics, and especially with medications, we see all of this interaction is extremely important. And one of the reasons why we, with the Pharmacy HIT Collaborative, formed we're in our 10th year now, was really the professional pharmacy associations came together, the national pharmacy associations came together to form the Pharmacy HIT Collaborative so we can focus on pharmacists that provide clinical services and how we integrate those services into our national health IT infrastructure. And this is one of the reasons why we've had such a close relationship with ONC and have tried to help in many ways of integrating our allied healthcare providers together with pharmacists. Our pharmacy systems are very different than many other systems, and most of the work that has been done on the pharmacy side has been in relationship to dispensing medications, including e-prescribing, which is one medication for a patient comes across one medication at a time. When pharmacists provide clinical services, these services are focused more on the patient as a whole. And we have a totally different review process that we do as pharmacists. We look at all the medications that the patients are on. So it has an entirely different workflow than our regular dispensing pharmacy management systems and those vendors. And so we've done quite a bit of work in trying to integrate more clinical services into what we do as pharmacists. Now, we do have regulatory requirements in relationship to clinical services, especially with the Medicare Part D program, which is for what we call medication therapy management services. All of these are focused not necessarily on one medication that was prescribed, but all the medications that the patient is on. And so we went down this path of looking at the workflow in relationship to how pharmacists document and share clinical services. And our clinical services include some of the health concerns, our assessments that we provide, even as an example, pharmacogenomic assessments on a patient for potential adverse drug reactions, all the way down to what we've observed, whether it's an A1C for diabetes or for blood pressure management, some of the disease management that takes place. And we also have many different encounters that we provide in terms of interventions in relationship to medications and recommendations of changing medication therapy based off of all the medications that the patient is on. And then we also begin to document our outcomes and share that in more of our team-based approach. This we see through the medical home model and other types of models where we take on a much more team-based role. Also with immunizations and immunization reconciliation, medication reconciliation, all of these are really important functions that pharmacists provide in relationship to looking at that patient in a very person-centered way, instead of just dispensing a prescription and then getting paid for that prescription. So this is something that we've done from pharmacy for a very long time. And so what we began to do, our professional organizations came together and defined a national workflow. And this workflow also what we call the pharmacist patient care process. And this workflow is also integrated into our colleges of pharmacy as we train our pharmacists. We also began to standardize our terminology with coding and work very closely with the National Library of Medicine's Value Set Authority Center. We've actually identified over 650 clinical terms within SNOMED CT International and within SNOMED for the U.S. realm that's overseen by the National Library of Medicine. And we have over 100 value sets that we work with our system vendors to actually incorporate those value sets into pick lists that make the clinical documentation a lot easier. And these are national initiatives for pharmacy. Like we've talked before and the others who have spoken today, pharmacy has a vast range of practice settings, from hospital to long-term post-acute care to clinics to specialty pharmacy to just a whole range in every type of pharmacy. So it's been difficult, but there are some very, very distinct paths and workflows that we are able to focus on with the vendors who participate in all of these areas. We, on the standardization, one of the biggest, we've worked very closely also with NCPDP, which is the National Council for Prescription Drug Programs, and harmonized our efforts with HL7. And when we started down a project on looking at care planning, we were lucky enough to connect with Community Care in North Carolina, which had a CMMI innovation grant. That's the Centers for Medicare and Medicaid Services Innovation Center. And we were able to help standardize the collection of clinical data, because we have some pharmacists, especially in the rural area or independent community pharmacies, that are documenting into 15 different systems. This becomes a real issue because we weren't able to standardize the workflow of working in one system. Now, with pharmacy, we've had quite a bit of good results with this, because pharmacy is very computerized, but we were computerized in terms of dispensing one patient, one prescription. And so we had to work with our system vendors to build out what we call their clinical module, which is an EHR type of process. Now, all of this has been done without any incentives from the government or others. A good example is what happened with e-prescribing. Pharmacists don't get paid, or it even costs us for receiving an electronic prescription, our actual pharmacists. This has been quite a bit of a problem, especially in our independent community pharmacies in rural areas. This just didn't have the funds to create this type of adoption. But we worked through it because there were good business needs and business incentives to have a good prescription that can be relied on and is communicated in a way that would increase patient safety and better outcomes. So we found workflow incentives for things like electronic prescribing. And we did something similar with our clinical workflow as we moved towards changing our payment models. We began to look at capturing more clinical information and sharing that information with other providers, payers, and even our patients themselves. And so we focused on the pharmacist electronic care plan and went through the standards development process that started at NCPDP, where we could recognize an implementation guide that was specific to pharmacy vendors, and then moved it over to HL7. When we did this project on the pharmacist care plan, which started around 2016, 2017, we actually were awarded a high impact pilot from ONC to work on this particular project. And we wrote the implementation guide for CCDA. And we also were lucky enough on our contractor to have a fire implementation guide also written. And because our pharmacists didn't have old legacy EHR systems, they were building out their clinical module. 99% of them adopted the fire resources because it made more sense and was much easier and faster to adopt fire. And they were on fire version 3. We, in May of 2019, we actually balloted for fire release 4 as we began to progress in making sure that we had information that can be easily exchanged with our other partners, our other parts of the care team, and have been very successful with the work that we've done with the pharmacist electronic care plan. We have a couple of networks. These are payer networks that are extremely interested and are receiving clinical, very codified clinical and structured data out of the use of the pharmacist's electronic care plan, where we've had hundreds of thousands of completed care plans and several initiatives. We now have around 86 schools of pharmacy that are adopting care planning and using the technology solutions to teach our students on how to care plan appropriately as we move forward with this type of implementation. We're hoping that our allied healthcare providers, therapy and dietary and others who are also building out similar types of electronic care plans will be able to look at the example that we did with the pharmacist care plan and begin to adopt very structured, codified information using the FHIR resources that can be shared in a very interoperable way. And this led us to working with the NIH and AHRQ on a project called the Multiple Chronic Conditions Care Plan. And this is a care plan that is centered on taking those high-risk patients with multiple chronic conditions and being able to share that with the care team, with the payer, with, and we hope, a care summary to the patients themselves, thereby engaging those patients. And these are aligned very closely to the regulatory requirements that pharmacists have, especially on the Medicare Part D program and some of our Medicaid programs. So we've been very successful in at least getting the message out that we need to begin to document in a very standard way and make that information interoperable with others of the care team. And this leads us really to our gaps and our barriers. And I think that from that standpoint, in order to meet interoperability, we have a lot of barriers that we have to cover. Many of our allied healthcare providers don't have the funds, and those vendors are usually smaller vendors and don't have the incentives or funds to build out this interoperable exchange. And it isn't just a matter of taking a FHIR resource and sending it to an EHR vendor. It's a matter of getting those EHR vendors to integrate this very rich structured data into the dashboards of the members of the care team. This is extremely important. Pharmacy works very closely with dietary, even therapy and the other allied healthcare professionals. As an example, for rehab, medications, depending, they might need pain medications, might need to know when the last dose of certain medications are given. And with dietary, there's many aspects that we work closely with the allied healthcare providers on. And having the ability of pharmacists to connect at that level in relationship to reconciling allergies, reconciling medications, reconciling immunizations. These are extremely important aspects of really taking care of the patient. And so I hope that ONC and others will take a look at our ancillary service providers and how we can connect in a better way and put some help and resources towards making those connections more of a reality. And with that, I'll turn that back over to you, Al.
Thank you, Shelley. We actually have a couple questions from the audience, and I don't know if you want to. I can read them to you, or if you can read them. The first one is a question from Ken Dominy from Physician Express, who asked if you have an idea about the time frame for implementation of the FHIR IG for the pharmacist care plan.
It was really quick. It was, and for some of the providers, or some of the vendors, for some of the vendors that were starting down the path of getting the idea of clinical documentation and hearing from their customers. Now, they were hearing from the pharmacist as the customers of the vendors who said, we need this. We need this in order to begin our process. So within 6 months, some of them were up and running. Others, it took well into a year, because it wasn't just a matter of building the FHIR resource for exchange. It was a matter of building out the clinical documentation workflow that didn't exist in many of the pharmacy systems. So we had a few vendors who actually had already built out a clinical module, and some of our dispensing vendors wrote an interface with that clinical module. So we had a few clinical modules that were out there that were already used for providing MTM services, or were built out for capturing other types of disease state management programs. And so we saw a wide range. Now we have a good, in the independent community pharmacy, I believe we have about 9 vendors who are up and running on the FHIR resource. And please don't quote me on the number of vendors. You could probably find this information under the technology tab for eCarePlanInitiative.com. An eCarePlan Initiative website was formed to really help these independent community pharmacies and vendors who were networking to increase the clinical service documentation and sharing them with payers like some of the state Medicaids. And so it was a range. It wasn't, but it was a lot faster than what we've seen in some of our other settings where clinical documentation is kept, such as in our consultant pharmacists who are servicing patients in long-term and post-acute care settings, and providing what we call medication regimen review, which is another regulatory requirement out of the CMS side on the payment model for nursing facilities. So we've had some success, and we have more to work on. But I can assure you that the vendors who aren't as familiar with CCDA found that the FHIR resources were much easier to work with and a lot faster in actually completing the capture, and even bringing information into their system, such as laboratory information or history and physical, or even discharge information from hospitals.
So I guess that about half answers my question. My follow-up question is that it sounds like there's been sort of ready uptake in the pharmacy systems. Has there been a lot of work with actually exchanging the information within exchanging and receiving and integrating the information in the pharmacist care plan into the hospital systems or the ambulatory systems?
No, and that's one of the main barriers that we see. We're able to export the information out to networks that are consolidating or sharing that with payers. And pharmacy has a long relationship with payers, and we work very closely with payers because we're not paid the same way especially under the Medicare Part B program. So we work very closely with health plans and with pharmacy benefit managers, and on the payer community side, a lot more than we do with the providers. One of the problems that we see with hospitals and providers, now we've tested, actually, one of the large system vendors, we tested receiving the electronic care plan through a Smart on FHIR app. So they're able to receive it, but we have no control over those organizations integrating the information into their provider's workflow. And that's one of the barriers that we see happening. We have very rich information related to allergies, related to potential adverse drug reactions, and even discontinuing and reasons for discontinuing medications. That is extremely helpful for the providers, but it will take those providers to integrate care planning into their systems a lot more readily than what we see.
Okay, are these care plans being when they're received by the requesting service? be it a provider's office or hospital, do you know if they are leaning towards integrating it as a consult result, or are they integrating it as just incoming clinical information or clinical diagnostic information sorts of things? Is it something like that, or is it something else?
It depends. It depends. Most of the connections on the provider to provider side, that means the pharmacist provider to the, let's say, a physician or a care team, it depends. Some, if they can't integrate that information, that using the FHIR resources into their system, break it apart, find the different pieces that fit into their workflow, then we don't see that happening. But if they do, and we do have a few relationships where we are seeing that happen, but it's still slow and very sporadic. It's not as consistent as we would like to see it. And that was one of the reasons why we focused on our payer. We focused on our payer model for a couple of reasons. Number one, in order for the adoption of this type of technology, we needed a payment mechanism for these pharmacists. So because we weren't getting incentives from the government any other way. So we had to focus on the payer model first. As we integrate into the provider model, we need some incentives, and those providers also need incentives to integrate into the workflow this very rich codified data in a way that now makes that data usable. And I think all providers struggle with that piece with their vendors in getting outside information consolidated in a way that becomes usable and integratable into the workflow of the providers. Just as you heard Alex and Chris and Chip talk, these are hard things to do. You're trying to struggle with bringing information into a system is the heavy lift. And I can tell you our pharmacy software vendors paid a lot of attention to the workflow, and that's why we've been successful. Out of the CommuniCare North Carolina model that we did, we found a 300% increase in productivity by those pharmacists who were documenting in 15 different systems, and now we're just documenting into one system. And that has helped tremendously with the profitability of those pharmacies in order to continue providing clinical services.
Yeah, great. Thank you. I have another question for you from Sandra Rout from DataWit. She asks, do you anticipate patients will be able to access the full care plan? Or I guess my take on that would be, is it in a patient readable plain text format, or can be made that way, or at least a summary to share with the patient either directly or through a portal to help with shared decision making with the patient?
That's a great question. And hello, Sandra. Nice to hear from you. The pharmacist electronic care plan is the meat of it, the basis of it, the architecture, the structure of it is just like any other electronic care plan coming, a FHIR resources being used in the e-care planning method. And that's why we're really excited about the multiple chronic condition effort. And you can find that information on HL7 web Confluence page under the patient care for MCC, or multiple chronic condition care planning. And this is an important piece because one of the processes that they're looking at is to create a care summary that would then be shared with the patient. Right now, when a vendor receives an electronic care plan, they have to break that information apart based off of the standard and begin to integrate the different sections into their work. And I believe that that's one of the applications on that particular NIH project that they're looking at, is creating a care summary. What we'll do is the pharmacist electronic care plan would be able to apply the care summary that would then be integrated with like a Smart on Fire or application or some application that would bump against personal health record or a cell phone app.
Thanks, Kelly. I was just going back through some of the questions. We provided a link to the pediatric health IT resources that ONC has published, and we also posted a link to the ASCA white paper that Alex was talking about. And you had mentioned a place to go for your for the eCare plan. And I don't think that we captured this in our answering of the questions, the 2 questions. But I'm gonna revoke one of the questions that you fielded and try and hang on a second. I hope I did this right. What did I just do? Oh, I think I may have deleted a question. Oh, wait. Oh, can you, Shelley? Can you refresh our memory on the link to the eCare plan website you were referring to?
Sure, it's ecareplaninitiative.com.
Any particular part of it, or just that's ecareplaninitiative.com. Okay.
Correct. And on there are the use cases that were developed, and those vendors that are FHIR and are ready to share a care plan. So this website was created by the Community Pharmacy Foundation, CPSN, which is the Community Pharmacy Enhanced Service Network, and the Pharmacy HIT Collaborative.
Okay, right. Thank you very much. And for those who are interested, I posted the link that Shelley mentioned, ecareplaninitiative.com, if you learn more about that. So Shelley, I wanted to ask you one more question, and then I think we're getting close to wrapping up, but are there, when we address a number of pediatric health IT requirements through the EHR format, and then with the refinement of the format and the recommendations, the priority recommendations, we did a lot of work at ONC to map existing certification requirements to those needs. And you mentioned a couple of them. You mentioned the use of CCDA. You mentioned the use of FHIR, and both of those are both specific certification criteria. Are there others that you can see that might help, if they might be able to help with the work that you're doing, or maybe future work that you're doing, or other requirements that really aren't addressed by some of the priorities recommendations in the pediatric realm, that you can say that maybe needs some additional development, whether it's in certification criteria or other technology?
Well, especially when you're looking at pediatrics, I think the most important piece, especially on medications. So when we met and was part of that expert group that came together on pediatrics, there were a lot of questions about height, weight, dosing, and what we did was we took some of those back to NCPDP that was able to incorporate some of that, at least into the prescribing module. In terms of the pharmacist electronic care plan, there should be no difference. We're able to capture very rich information no matter what age that patient is. We have very similar types of issues with geriatrics. When you're looking at a geriatric patient, especially in relationship to medications, there's very, very similar types of information that we need to share and be part of. The example being the creatinine clearance effects on kidney functionality of a geriatric patient. So very similar, what you see in pediatrics, you see in geriatrics. And so as the pharmacist is documenting and part of that process, instead of the pharmacist going in and logging into the EHR of the pediatric EHR, We hope that we'll be able to pull that type of information and share it in an interoperable bidirectional exchange with the pediatric clinic or clinicians and care team that are taking care of those patients. So we're more than willing to help and work on those initiatives. We do have some pharmacists that are specialize in pediatrics, just as we have many pharmacists who specialize in geriatrics and in other types of disease states, that we work with those vendors to make sure that their workflow is consistent, but that we can exchange information in an interoperable way. I hope I answered your question, Al.
You did, thank you. And I think it's good to keep the creative juices flowing when you think about how to solve problems, even problems that we don't quite know about, or they're just sort of lingering in the backs of our heads. I do not have, hang on a second, let's see, let's go back to questions. We have any new questions? We do not. I think just wanted to give everybody, our panelists, an opportunity to say any last words or reminders for anybody. I did want to thank everybody for participating. I think this was a great discussion. And if I'd give everybody a chance to chime in for some final words.
None from me, except to say I'm impressed that so many people stuck with it for the entire hour. We've been between 70 and 80 people this entire time.
Yeah, we started at 60, and I guess people got bored with the other rooms and decided to crash our party. So I'm happy about that as well. Yeah,
there we go.
Okay. Again, I wanted to. Oh, I'm sorry, Alex. Were you going to say something?
No.
Oh, I thought. Okay. Thank you, everybody, including the audience that posed the questions. We're actually going to be able to wrap up a little bit early today, which is I don't think anybody's going to complain. You'll be getting some instructions. The attendees will be getting some instructions about being able to access the recording, which should be available in about an hour. And you should get a link if you are a registered attendee. You should get a link of some sort. I don't know exactly what that'll look like. But if you want to come back and review, if you did not capture the links, you can come back and review the links. Alex asked the question about our contact information. I think that if you have, I think this is a question for Matt. You can reach out to me at ONC if you're interested in getting people's contact information. No, the links are not. Our contact information is not on the links, shockingly enough. But we're both. So I don't have our contact information to give out to you, but. Just feel free to reach out to me at ONC, albert.taylor@hhs.gov, if you have additional questions for me or the other panelists. Okay. Well, thanks everybody. We're going to adjourn a little bit early, and thanks again for coming and off to a break, and then back to some more sessions this afternoon. Thank you, everybody.
Thank you.
Thank you.
Thank you.